Good to have you with us today on the Healthcare Leadership Excellence Podcast. I don't even know how many times we've had our guest on the show.
Can I just be a periodic co-host? How about that?
I would love that.
How about that? I mean,
So,
come on. Let's just do that title, because then every time you say here's our guest, like then you say how many times periodic co-host, and then you don't even have to put a qualifier in there.
there we go. So the voice you hear joining in there is Dr. Rob Orman, an amazing colleague, a superb coach, host of the Stimulus podcast, which he's run since 2020, so coming on 6 years. And Rob, delighted to have you with us.
Always a treat, my friend.
So today we're going to jump right in. Rob just sends out these podcast or this writing every once in a while. Couple of times a month, Rob, is it?
Generally 2 times a month. It's been as I'm currently writing a book. That's where my focus has been. So the newsletter has been less frequent, but usually every other week.
Okay. So um, uh, quite frequently I get these, and my first thought is, okay, yeah, that's podcast topic. So I think we're about two or three behind, and we are going to go over. I'm going to commit us on air here, Rob.
Okay.
There is a book called The Go-Giver, and Rob told me about this book, and I read it through, and this will be a real treat in 2026 for you, our listeners, because this is a dynamite book. And I can imagine with the way Rob and I get going that it could be, it could go into a couple of hours. We'll have to divide up so our editors don't kill us. But let's jump in right now because two of the things that Rob had written about, um, Rob is an expert on coaching physicians that are in burnout, in transition. He goes extremely deep on this topic, is passionate about it. And today we're going to talk about some tools to take back control and also how to handle the imposter syndrome. And we've got a few minutes in front of us here. So, Rob, talk to us about these tools for taking back control.
You know, you and I do a lot of behavioral coaching with physicians who have difficulty aligning their behavior with the cultural norms of the hospital or the healthcare system. And let's just use that as kind of the far end of the bell curve of docs who want to do a great job, are almost always great clinicians, but in some way have this compression of the space between stimulus and response. And I mean, this is kind of all of us, right? We get ramped up and amped up, and we just kind of we lose our heads. But I want to use this particular cohort as an example because it's so apparent and the stakes are so high. And so what a lot of the work with these docs involves is increasing that space between whatever is the external stimulus and their response. And I was speaking with a client the other day, and this may get into what we talk about. And we were talking about different tools. And this is someone who is utterly brilliant, and you give them an idea and they take it 10x and make it better. And so they were describing a situation where they were, presented with a stimulus that before would have really sent them off. And they started thinking about how they were going to respond. Do I use this tool? Do I use that tool? Do I use this tool? Do I use that tool? Maybe some of the tools we're going to talk about today. And then they responded in a nice way. And they said, I'm not sure if I used the right tool. I said, wait a second. You did the best possible thing, which was expanding the space. You were thinking about how I respond. So you were responding instead of reacting. And so any of these what I can't remember what the original topic was. So the tools to downregulate or the tools to take back control. I guess that would be because in these situations when you are reactive, you are in some ways out of control. So we can get into the specifics in a moment, but let me pause on all of that.
You just said a phrase that I love because one of the topics that has come out of the Harvard Project on Negotiation is the item of going to the bridge, of going to the balcony, taking a pause, and your phrase of responding rather than reacting. I mean, if our listeners can take away one thing today, it would be Rob digging into how to be a responder when things are flying fast and furious instead of our limbic system saying react. Talk to us more of how to get to the respond level of maturity.
And I wanna put an asterisk on that. As you're talking to that, what pops up in my mind is when 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 you and I speak with administrators, oftentimes it's a CMO or the risk manager, and they're asking about the program of,
Mm.
well, does the behavioral working work? The behavioral coaching work? Do you think it'll work with this doc? And it's well, it's 100% effective. It's 100% effective if the doc is invested, if they want to do it. If they are not, it is 0% effective.
Mm.
So these are things that they will work if you apply them. If you think they are BS, then they won't work. So and it feels funny when I say, and I imagine that you say that as well, that, yeah, this works every time. They might not be perfect, but they're going to get better.
So I want to take you on a side tangent here that I've given you no preparation for
Okay.
whatsoever.
Okay.
But as you do, I also do. I get referrals from medical executive departments and MECs and the med staff. And we get the email saying Dr. John Doe, because he's now on a performance improvement plan, the infamous PIP, um, he needs 10 sessions of coaching with you over a 6-month period. And you talk about reluctance. I mean, most doctors, and generally now with medical economics, the provider themselves is paying. So on this call, there are people listening who are on those MECs and on those med staffs. As a physician yourself, could you give a little guidance here on how an MEC or a med staff committee can help set the whole coaching process up for better success, other than saying, you screwed up, we've got complaints, you need to address your communication. Here's Rob Orman or Carl Peaster. You need to contact him and get scheduled within 2 weeks. Actual call that happened yesterday with me. And you need to sign a release that allows Rob or Carl to get back with us to describe engagement, improvement, meeting of goals. Can you give some guidance of how to make that a more palatable and successful process?
Well, I think the first part of that is the physician is going to feel like they're under the microscope and that there is an existential threat. Just know that going in. And for you, oftentimes, almost every time, these are born out of frustration. And you think, oh my gosh, we've got to do this administrative thing to either salvage this physician or have the check the box that we did this before we fire this person.
Mhm.
It might be that this person has, some sort of psychopathy or narcissistic personality disorder and nothing is going to fix them. That might happen. That's usually not the case. This is usually someone who is really struggling and probably has a blind spot. And when these docs come to us, when they open up, I say, I'm not sure what I'm doing, or I don't know how to change. I don't know how to change. And it is utter fear. This strikes at their identity. This strikes at, also their livelihood. And so there's so much at stake for them. And it feels 100% punitive. And so I think that taking that into account, that, wow, there's probably going to be some defensiveness, and that's okay. That, most docs aren't going to say, oh, thank you so much for giving me coaching. That's fine. When they get to us, we will walk them through it and normalize it and let them know that they have a champion. We're not going to condone behavior, but that this coaching is for you. And, when we speak to most of these administrators, they say, we want this doc to make it. They are so valuable. They're such a great doc. So just expect that there's going to be defensiveness. Just expect that there's going to be fear and maybe some reactivity and reluctance. And that oftentimes when the docs come to coaching, they feel voluntold to do it. Not that, when a doc comes to coaching for burnout, they're driving themselves. Mm-hmm. I will say that, and I don't know that I'm actually directly addressing the question. One reason that behavioral coaching is my favorite kind of coaching is because there is a very clear endpoint, and the doc is 100% invested if they're invested. Mm-hmm. And so because the endpoint is coming off the PIP, the real endpoint is improving their life and their clinical situation and finding joy. So I would say that when you do this, when you are talking to the doc, just take a half step back and don't get sucked into whatever is the whirlpool of the drama or the angst or the anxiety, but not 2 steps back so that you don't have compassion for them. How does that land?
Wow, perfect. Exactly. And I love that half step back and not letting the frustration take over. So, big surprise, Rob, that Carl took you on a complete tangent of the original topic, but as our listeners will know, that is not uncommon. So, back to the topic of getting control.
Okay.
Part of your writing hits something really close to home, because I know, and I think that how we talk to ourselves and how we set ourselves up just by that script in our mind is huge in establishing control. Yet you said something really important on these affirmations and visualizations that are really effective, but especially on the affirmation. You said, it's important, but not sugar-coated. So, and that really, wow, because a lot of self-talk is, to be comical here, I'm wonderful, I think I'm marvelous, and everyone else will too, and that's obviously a bit sarcastic. But in your writing, you really hit it on the head of, it's an affirmation, but let's not sugarcoat it too much. Dive deep for us on that one.
So there's nothing intrinsic to either one of these that, well, one should work and one shouldn't. It's just the research on this shows that positive affirmations, especially for high-level achievers, can increase distress. I mean, and that sounds crazy. You think this is different than having a goal of, okay, I am setting this endpoint and I know the steps to get it, and I'm going to get there. I'm going to look at the obstacle. This is different. This is, your mind is just screaming, you are not enough. You are going to blow it. And you get all Stuart Smalley on it, who is the character from Saturday Night Live. I'm good enough. I'm strong enough. And by golly, people like me. So that right. Every self-help book from the 80s and 90s. And so that's kind of a forced positivity. And you think, wow, well, that sounds like it should work. Stuart Smalley did it. And look at all those affirmational posters that are all over business offices and such. So that is known as thought replacement, that you're trying to replace that negative thought with a positive one. And that doesn't really work when you're under stress. Now, there are aspects of this that we can get to that do work for de-escalation, but a better move and what is more evidence-based is objectively noting what the thought is. And this comes from this phrasing, not the idea, but the phrasing of this comes from acceptance commitment therapy, which is I'm accepting what my self-talk is. So instead of, you think like, oh, I'm gonna blow it. No, wait a second. I'm powerful. I'm superhuman. You say to yourself, oh, I notice I have the thought that I'm going to blow it. I notice that I have that thought. And what that does is more potently than thought replacement is it reduces that intense negative valence or power of whatever is that ruminative, negative talk you have going in your mind. So you just accept it. Because really, when you try to replace it, you're trying to run away from it or you're trying to suppress it. But when you turn towards it and think, okay, oh, here's that thought. Oh, I notice I have that thought. Don't love it, but I notice that I'm having that thought. That works more effectively than distraction or thought replacement.
Got it. You also talk about correct visualization and the importance of ending a visualization on a high.
Yeah.
Talk to us, because affirmations are one thing, and correct me here if I'm wrong, but I've always used visualizations as affirmations on steroids. Just really having a detailed conception of exactly what I want it to be. And not with Stuart. I just love that Stuart Smalley piece. Not with that level, but truly creating it mentally before I create it physically. That when it actually happens, it's kind of, yeah, I've been there. Now I'm seeing it, but I've seen it before. So where am I off? Where am I on there?
Well, that's a really interesting juxtaposition of the thought replacement and the visualization. So the thought replacement, that's kind of this value judgment of I'm not enough. I am enough. Oh, I notice I have the thought that I'm not enough. That's all judgment. That's all subjective. The visualization is objective. So, for example, you're doing a procedure and you kind of flub it. Mm-hmm. Okay, in comes the criticism of, oh, wow, do you suck? Mm-hmm. Oh, wow, do you suck? There's a judgment. Let me downregulate. We talk about actually how to downregulate in that moment. But one part of this is, well, let me take a pause and visualize this to the win, to the end. It's like that future journaling that you taught me about long ago, of you're almost writing in the past tense, that you're seeing it all the way to the win. Mm-hmm. And so rather than, all right, I'm just going to see this first step of it, I'm going to, let's say you're doing a thoracotomy, so that's a procedure where you're opening someone's chest, you're basically pulling the heart out of the chest a little bit, opening up the pericardium, the sac around the heart, pulling out the blood clot, maybe sewing up the heart. So ultimately, you would want that patient to be in the operating room getting stabilized. And most of those patients die, but it's also a very high pressure and needs to be rapidly done situation. So visualizing that, maybe there's a guess it's how would we describe it? Like a vice that you turn a handle on and it opens up the chest, and sometimes it gets put on the wrong way. And so that can really, put you off your rhythm. It's like, all right, so, let me visualize this to completion. So I'm going to visualize this step, this step, this step, and then I'm going to see the patient going up to the operating room. And I'm doing this from first person through my eyes. See the person going to the operating room and then leaving the hospital.
Mhm.
And, in the moment, that would need to be done very quickly. But what that does, imagery taking it to the end point. And just like with the self-talk, there's no reason why, there's that, well, does this work or does this not? So this has been studied. And what is found is that when you take that, it improves your technical precision. And that's been, shown in surgery. So which is a, perfect medical substrate for which to study this. But in the brain, when you mess up or when things aren't going your way, you can start catastrophizing and your limbic system fires up. When you have what would be considered future oriented positive imagery, I see it going all the way to the end. This is not subjective of, wow, you're the best. This is, oh, I'm taking this to the end. That has been shown to reduce anxiety and also improves performance under pressure.
Talking about anxiety,
Yeah.
you would have to live in a cave not to have read or experienced or listened to somebody talking about triggers.
Yeah.
And in this writing back in July, nearly 6 months ago now, where you wrote about anchoring with trigger words. What that, wow, I always think of trigger words as kind of almost a cop out. Well, I was triggered. Talk to us about how this plays into the control and getting control back.
I'm not sure what kind of conditioning this is. Maybe it's operant conditioning, or I just keep picturing Pavlov's dog, but that has just negative connotations these days with what they take those poor dogs. So this is a trigger word or a cue word. And this is something that, let's just pick that same situation where you're doing a procedure, things aren't going well, and you need to recenter, recalibrate, get yourself relaxed. Or even, for me in emergency medicine, it's, the patient's coming in, multiple gunshot wounds, unstable, going to need to do multiple procedures at once. Whew, I can feel my heart pounding now, just picturing it. So you need very steady hands. You need a clear mind for that. And we can talk a bit about the physiology of that, but how do I want to feel at my peak performance state? I want to feel a certain degree of tension because I don't want to be fully relaxed. So I want a certain degree of tension where I am focused. And what that is generally going to mean when you're amped up is that you need to downregulate. You need to bring yourself down, because usually when you're under stress, there's going to be some just residual tension regardless of what you do. So a trigger word or a cue word is something that you train your mind to associate with a relaxed or focused state. You can't use it for the first time under pressure. It doesn't work anything. Wait, it's not working. It's not working. So the way that the association works is, well, Carl, what's something that you do where you are focused yet relaxed?
Focused yet relaxed. I would say wood carving.
Wood carving. I love it. So you would pick a word, and the word isn't important exactly what the word is, just has to be good for you. So if there's situations where you find yourself amped up, let's say you're in a meeting with all of the CEOs of all the different hospitals of a hospital system, and they're all fighting and they're saying, Carl, you need to fix it, and this is that, and everybody's mad at each other. And Carl thinks, I need to focus this in. This is getting really amped up. So maybe it's, I don't know, what might your focus word be?
And I don't want to sound like I'm just going by the research, but what's really my brain goes all over the place.
Yeah.
Yet if I just, my phrase would be present.
Be present. Love it. Be present. So when you are wood carving and you're in that state where time is slipping away, you're losing self-referential thought, you say to yourself, be present, be present, be present. Next time you're wood carving, be present, be present. And you're using that association with that state so that when you're in the moment of heightened distress or heightened stress, when you say that, it's not necessarily that it'll turn on, but you're able to associate it in the moment with, this is that focused, present, mindful state that I need to be excellent. And so be present is then able to take you out of scattered mind and bring you into focused mind.
Excellent. So we're going to have some eye rolls on my next question
Sure.
because you and I both work with high drive, genius level people that when we bring up what I'm going to bring up, it's kind of like, oh, please, Carl, give me something that works. And yet I love the phrase because I'd never seen it written like this of gratitudinal flooding. And both of us, we've talked on past podcasts about this. You've written about it, I've written about it, that this little thing of thinking in a gratitude mindset isn't just little, it's huge. And yet I've talked to people. I had one cardiothoracic surgeon, incredible mind, highly successful, look at me as kind of, that's the best you can do is say that I should be more grateful, Carl. It was kind of, fortunately, it all ended up well. But I remember his first response was, are you freaking kidding me? You know, I've got administration just down my throat.
Yeah.
The nurses hate me. I'm one of the best in the nation. My volumes are incredible. My outcomes are in the top 1%.
Yeah.
And you're telling me that I need to think gratefully? So when I had someone at your level talk about gratitudinal flooding, take it away.
Whoa, you brought up so many great things here, and I want to make sure we get all our stuff in on this podcast. So this term, and I think, I'm not sure if this term was made up by my partner or it was just the concept. And I'm not sure where to give attribution for this, but this came from a retreat that I was running with some friends and coaching partners, where it was pretty much everybody was in healthcare, and we were getting into some intense stuff and how to manage it. And a couple of docs brought up pediatric resuscitations where there is a very sick child, or you're doing CPR on the child and the parents are at the bedside. I mean, or even you tell parents that their child has leukemia and you are picturing your own, and it's just so intense and overwhelming.
I get chills as you talk about that.
Yeah, it's like, I imagine that any clinician here is picturing situations like that they've been in. It might not be that exact one, but it's there for all of us. There are situations which are just a lot. And the gratitudinal flooding came from one of my partners who's an intensivist. And when he's in those situations, what he said in this retreat was, I flood myself with gratitude. And so I think at that moment, how grateful I am that my son is alive and that I get to go home and see him. I have such compassion for these people. I'm so grateful for my child. And whereas you can just take your kids for granted. And so that for him was his reset. And, I, as in addition to your cardiothoracic surgeon, was skeptical about gratitude, even though we have all felt it. We know that when we feel gratitude, we feel great. That just is. It triggers the nice, positive, feely parts of the brain. But what I found in researching this is that there are different types of gratitude. There is a trait gratitude, which is, there's just some people who are just grateful for life and they walk around just kind of happy. That's not what we're talking about. What we're talking about is state gratitude, which is this is momentary, intentionally evoking a feeling of gratitude. So trait gratitude, that's just kind of the general disposition that I'm thankful for things. State gratitude, when you can bring on gratitude in the moment, that, and this is, this resonates with doctors, the evidence shows that it lowers sympathetic activation, it lowers limbic system, fight or flight activity. So your brain comes out of threat mode. Why do people act out? Why is that cardiothoracic surgeon is talking? They feel like they are under threat. So their autonomic nervous system is happier with gratitude. It also reduces negative affect, so likely to interact with people in a nicer fashion. And it also, when you have state gratitude under a stressful situation, it can reduce rumination about that event and stress about that event later on.
So it's always been amazing for me why, even when I'm talking to physicians,
Yeah.
and I introduce some of this, pulling back and helping that autonomic and somatic nervous system to disengage and feeding off of each other. What's the science behind, as you so poignantly said, and that hits home because I'm working with a pediatric CICU unit in another part of the country. And to see these small children in these compromised states just is heartrending. But to think I am grateful that I have a child that's alive and I have compassion toward the parents right now. What's going on biologically that slows down that reactivity and allows something that wouldn't even be thought about? Because some of the physicians, when I present this to them, they're kind of, really? So what's the research behind that? What's happening?
This is going to be, well, I want to speak to that in a couple different ways. There are many different avenues with which to study this. Sometimes it's subjective report. Oftentimes it's in fMRI, so you can see what parts of the brain are lighting up. There can also be HRV or heart rate variability, seeing is your sympathetic nervous system active or is it your parasympathetic chill nervous system? So there's many different modalities with which to study this, but it's overwhelming, the evidence on all of these things that we've been talking about, that they slow down or turn off the parts of the brain and the parts of the body that are associated with negative stress. Sympathetic overactivation, limbic system overactivation. Sometimes your limbic system you need, you got to run from that tiger. Yeah, that's flight. So everything we've talked about though is cognitive. Talking about thinking your way through this. Sometimes your physiology is so amped up that no amount of thinking is gonna win. And when that's a situation, just go to your breath. Not, hey, sit down, focus on your breath in meditative mindful state. Breathe in for 1, breathe out for 2 in that ratio. So breathe in for 4, breathe out for 8, breathe in for 3, breathe out for 6. If you breathe in a 1 inhale, 2 exhale ratio, that is the optimal parasympathetic activating breath pattern. And because, if your tachometer is way buried in the red line, you can't think. So you just breathe. And breathing, here for all the physicians in the audience, breathing through the nose is a critical aspect of this. Nitric oxide is produced by the nasal mucosa. So when you breathe in through the nose, that gets down into your lungs. It vasodilates in your lungs. It lowers cardiac output. It, it improves oxygenation. And also breathing in through the nose and actually just nasal breathing activates the trigeminal nerve, which is parasympathetically activating. You can breathe in through the nose and out through the mouth. And this isn't just in medicine. This is in the military. Navy SEALs do this kind of breathing, right? It's this kind of, wow, you're telling me a doctor's like, okay, well, let's go to combat in the Middle East, and you are, in an alleyway, and you need to control yourself before you go run across under fire. Well, the first thing you're going to do is take a couple breaths in this pattern.
And I just chuckle because I forget the title of the book, but it was written post 9/11, where the author, she was talking about the same thing that Navy SEALs use and police in high stress situations use. It's the same breathing that they teach expectant mothers. I mean,
yes, right.
One group says it's combat breathing, the other group says it's childbirth breathing. So it obviously works.
Now,
And
I do want to put one caveat onto all of this. I set up in the beginning about using docs who are referred to us for behavioral coaching, and that these are all things which can work for them. These are tools which are third level tools. In the beginning of that kind of work, we're building awareness of when the stress comes up, when there's this stuff, this is the advanced level. This is varsity. You got to start with training wheels in the beginning and get up to the varsity level. So I just wanted to put that caveat in there.
Super. Rob, tell people how they can get a hold of more of your material.
You can find it all at Rob Orman, my name, ROBORMAN.com.
Perfect. And before we started the call, I was running through the agenda with Rob, and he said, Carl, we're not going to get to half of it.
You sent me like 12 different topics. There's no way we're getting to it.
So we have thoroughly dug into one, and listeners, just know that you have another treat coming up in 2026 to have Rob and I again. And I may pursue this co-host bit. Rob, thanks so much for spending time with us today. I appreciate it as always.
Always a treat, my friend.